So good evening, everyone, and welcome to our third echo session of our Enhancing Palliative Care series. This session will focus mainly on deprescribing, and Julian Soriano will be our presenter. Another huge topic, and as always, Julian will be joined by our core panel. Okay, so as I've mentioned, this is session number 3. I'd just like to start by acknowledging country, and so we acknowledge the Kaurna peoples, who are the traditional custodians of the Adelaide region. We pay tribute to their physical and spiritual connections to land, waters and community, enduring now as it has been throughout time. We pay respect to them, their culture and to elders past and present. We would also like to acknowledge and pay respect to those Aboriginal and Torres Strait Islander people from other nations who live, work, travel and contribute to Kaurna country. As we've mentioned in our previous sessions, our project is supported by funding from SA Health through the Palliative Care 2022 Grants Project and delivered to you by us here at GP Partners Australia. Just some housekeeping and general reminders. We'd like you to introduce yourself in the chat. Let us know where you're joining from and your role. Your microphones are muted. There will be lots of time, however, during the session for your comments and discussions and questions. You're welcome to use the chat function to ask questions if you have any comments or having any technical details, but also feel free to raise your hand. The didactic session will be recorded and will be emailed to you within the coming weeks. And I think those that received my email today will have received all the links and presentations from our last session. So if there's any queries, once you've looked through that, please feel free to contact us. Remember not to disclose any personal health information during the session. And again, as always, we hope that you enjoy and get a lot out of our session. So how the echo sessions work, you're becoming very familiar with that, I guess. We'll have our introductions, the didactic presentation, and I've said tonight from Julian, and then our interactive case-based presentation discussion will follow. As always, we're really keen for you to become a case presenter. So if you would like to submit a case, or you have a case that you might need some input from our core panel from, please feel free to let us know in the chat, or you can contact me directly or send the case through on the template that I've provided you, or you can let us know via our website link. You've got the program, so we're up to session 3, as we said, the 12th of October. So now I'll just introduce our team again. By now you know my name's Leanne and I'm here as the General Manager from GP Partners Australia and lead of this ECHO series. And my team will introduce themselves as we go around the table.
Sure. Hi, I'm Atif and I'll be providing the IT support for my session.
Hi, I'm Naomi and I'm the Network Coordinator and Website Manager.
I'm Julian, I'm a Palliative Care Pharmacist and you'll be hearing a bit more from me in a minute, so I'll be quiet now.
I'm Olivia, I'm a Palliative Care Consultant now. It's finally official.
Congratulations.
Oh, that's it. I thought you could say something more.
No, that's
Now, short and sharp.
The exciting world of being a consultant. Hi, I'm Russell and I'm GP. And yes, it's good to have you along.
Excellent. So now I'll hand over to Russell and he will introduce Julian and we'll get the session started.
Yeah, thanks, Leanne. So the didactic presentation that we've got tonight is going to focus on palliative pharmacotherapy, or in actual fact on deprescribing. I think is what Julian's going to talk to us about. It's no surprise to anybody really that pharmacists have a significant role in the care of all Australians, especially with palliative care needs. So they could be caring for people hospital, residential aged care facility, which Julian does a lot of, a hospice within their community at home. And as members of multi-D palliative care teams, they've taken a range of roles and responsibilities. So we would like to acknowledge the role that pharmacists play in providing team-based palliative care for Australians. They can provide advice on medication management, including prescribing, including off-label and anticipatory prescribing, administration and deprescribing in line with rational use of medicines. So Julian's presentation will elaborate on that last point and give you a lot more, I'm sure. So thank you very much, Julian.
Thank you, Russell. All right, I'm just going to do the awkward share my screen dance. Give me a moment. All right, can everyone see that? I think we can.
Yep.
How does that look? Lovely, cool. All right, thank you for that introduction, Russell. And yes, as we've mentioned, tonight's presentation is going to be about deprescribing. I think Olivia and then Paul on the last session did a really good job of covering a lot of therapeutics and use of medications. So I thought anything I really had to add to that would have been quite repetitive, and I didn't want to bore all you guys. So we've decided to go down the deprescribing path. I think this is still something that's really important for our patients, particularly palliative care patients, and doing it right can be quite tricky, but have some really, really good outcomes. Just a little bit about myself for those who haven't been at the other meetings. So I'm a pharmacist and I work in two roles. I work as an embedded aged care pharmacist, so work on site at Tanunda Lutheran Home in the Barossa, and I also work as a project facilitator for the Southern Adelaide Palliative Service. And there we've been running some projects related to hospital prevention and palliative care at home for patients who engage with the Southern Adelaide service. So for tonight's presentation, I know it's supposed to be didactic, but I'd really enjoy if there is feedback or questions or comments from people in the audience. You can either send them through the chat and they'll get flagged to me, or is it illegal for them to take themselves off mute and ask questions? Is that okay? Got the nod. So if you prefer to do that, please do. I also have some Slido polls. So you'll see on the next slide, there'll be a QR code pop up. So if everyone wants to grab their phones out, you'll be able to scan the QR code. So QR codes aren't gone yet. And it'll take you to a polling website where you'll be able to answer questions and provide some of the content here as well. So again, it's good to hear from you guys. It's a bit tricky making these presentations because not having met many of you, it's hard to know what you might want or not want to hear. So we're going to have a brief summary, sort of high-level look at deprescribing tonight, and I'm going to talk a little bit more about some of the processes and techniques and resources, as opposed to some of the specifics of deprescribing. And I'll go through a little bit of why I thought that's maybe the best approach through the presentation. But we're going to talk about what is deprescribing, talk a little bit about why deprescribe, which is, I think, a lot of patients will ask you as well when you go through this process. Some opportunities to deprescribe. I think looking at deprescribing during moments of care is a simple way and a clear way to do that. The process of deprescribing, and then some resources that I find really useful for when deprescribing has to happen. Alrighty, as foreshadowed, here is our QR code. So if you scan this on your phone and visit the website, it should hopefully work. It's popped up straight away, which is good. And the question I've asked is, what do you think of when you hear the term deprescribing? So you'll be able to input one word at a time. You can input as many words as you want. And if all is working, your answers will appear on the screen in a sort of pattern. So this is, yeah, just sort of an introduction to this. I'll give you guys about 30 seconds to a minute to do that. Excellent. About rationalizing, I really like that. It's, oh, I've got a whole bunch popped up.
All at once.
Yeah. Awesome. I love the engagement straight away, guys. Lifespan, I think, would be 2 words together there. Medications, essential. So yeah, that rationalizing, that essential are 2 really key and important things, I think, that we really focus on. Ceasing, changing dosage of regular medications. Yep. And that's something else that maybe we don't think of as much as deprescribing, but it's not necessarily stopping a medication, but it could be just reducing. Crushing I'm assuming it's crushing medications. That's something I'm quite passionate about, and you'll hear a bit about through the presentation. So yeah, absolutely. Yeah, so I think that's a really good list so far. I pre-made a list, but I think I pre-made some answers to that, but I think a lot of what you guys have mentioned is there.
This word is great, individualizing.
That is one of the really important parts, and that is why I'm not necessarily going to focus too much about some of the specific evidence surrounding some of the deprescribing, because it's really tricky, because you've got to do it based on the person that's in front of you. And these presentations could go for days if we're sort of talking through all of those scenarios. So I think the old teach a man to fish adage might work. Yeah. So what is deprescribing? So I've gone and found a quote, a definition. This is from Emily Reeve, who's a fantastic deprescribing pharmacist based in South Australia. So she's written a lot of papers and research around it. But deprescribing is the planned and supervised process of dose reduction or stopping. So both of those were really mentioned a few times on the previous slide, the fact of stopping and reducing. But also the word planned, I think, is a really important aspect to this as well. So stopping of medications that might be causing harm or no longer of benefit. So that no longer benefit part, I think, really fits that rationalizing component. Deprescribing is part of good prescribing, backing off when doses are too high or stopping medications that are no longer needed. So I think that's quite a general view of deprescribing. There's lots of different definitions online, all maybe technically a little bit different, but I think they all touch on the same general theme. And then to Olivia's point before, that individualized, and I've got that word highlighted too, so I didn't put that in, but also the patient-centered individualized component of this is really important. And deprescribing can get a little bit tricky because the patient may not necessarily want to follow what best practice might dictate, and that's a really important thing that we need to work with and work on. So why do we deprescribe? Why do we go through the bother? So there can be lots of benefits to patients, reducing medication burden and complexity, particularly in the geriatric space, and a lot of the time that geriatric space and palliative care will cross over. A lot of the work I do in aged care homes, they're very closely tied. But people will accumulate lots and lots of medications over their lifetime, and if the deprescribing process isn't gone through, that can become quite burdensome for them. It can increase things like polypharmacy, the harm that you might expect from polypharmacy, but just making a medication regimen is quite complicated. So multiple dose times during the day, increased confusion about when to take medications, and sometimes that can lead to very important medications taken at inappropriate times. Reducing the risk of falls, put a little star there. The evidence of that, again, is very individualized. Some studies are saying that there's good evidence to indicate falls risk is reduced, and some studies say not so much. I think this is really coming down to what we're prescribing and particular residents, but something that I see a lot in my work is when residents are having falls, looking at medications and what medications could be contributing, and then can we deprescribe is normally a component of that. Improving and preserving cognitive function. So we're particularly thinking of heavy sedative medications here, and a medication group that's been sort of under the spotlight recently are anticholinergic medications. So they can be medications that can be quite burdensome on our patients. Reducing the risk of hospitalization and death. Again, start with that one. Evidence is up and about for that one. I like to think that, yeah, we're going to make a huge difference. But again, looking at the individual in front of us, reducing medication-related harm can be reduce sort of the utilization of healthcare services around them. And particularly that part of reduce the risk of hospitalization We'll talk a little bit about tapering and deprescribing doses early, but that can be something that can reduce a palliative care patient's hospital stay in the long run. Reducing risk of med harm, we've covered that quite a bit. And cost saving, I've written residents, I do this a lot, patients. I've got my aged care hat on. But yeah, cost savings for our patients and people looking after. Medications can be quite costly. Thankfully, in Australia, we've got a very good system that looks after us there. But there are some medications that particularly fall outside of your PBS, and particularly thinking of things like vitamins and over-the-counter supplements. While they can be helpful, sometimes like a single bottle of fish oil ends up costing more than a patient's entire list of medications. So it can be something to consider. Another reason to deprescribe is a lot of time patients seem to want to have their medications changed. So again, Emily Reeve, she's going to be mentioned a few times here. But this was from a paper, this graphic is from a paper that she wrote a while ago, looking at the prescribing attitudes of patients. And overwhelmingly, so around that kind of 90% of patients would be willing to stop regular medications if their GP or their doctor had asked them to, and over about 60% would like to reduce the number of medications they're taking. And this, I think, reflects a lot of what I've seen in the community when I've gone to do home medicine reviews. A lot of patients will say to me, look, I think I'm taking too many medications. I rattle when I go to the shop is always a really fun one from them. So it's something that a lot of patients will be on board with, but I also think we should note that there's also a population or proportion there that aren't necessarily ready for deprescribing or overly enthusiastic about it yet. And a lot of that could come down to understanding. Looking at patients' medication lists, so this is touching on that polypharmacy side. And this is maybe approaching a little bit of that geriatric medicine rather than palliative care, but what we also seem to see towards the end of life is medications begin to be added on. So patients' medications list size will expand and they'll start getting into that territory of, now I'm definitely on too many medications, what can go missing here? So around that sort of 10 to 12 medication mark is when the majority of patients start to say, look, I think I'm taking too many medications. And that's when we start to think medication-related misadventure might begin, related to adherence and conformance and supply and polypharmacy. So a little bit of when to deprescribe. So I like to think of deprescribing as sort of in stages and in phases, and it's normally the way I've seen practice happen is the deprescribing conversation normally occurs around significant events. So one of those is normally around the changes to the goals of care. So that might be a change to life expectancy, a new diagnosis, a particular event, something like a fall, a hip fracture, a change in mobility, a change in what the person might expect out of life or what their focus is, which is obviously the core essence of palliative care. There is we're looking to improve function and quality of life rather than maybe extending it. So yeah, deprescribing is normally is a really good, well, this is often a good time to approach deprescribing. And it can be approached really early in the palliative care journey. So not just at the end of life. Sometimes I've heard it called the geriatrician salute, but we kind of just start crossing things off the med chart at the end, sort of towards the end of life. Having that done in a slow, methodical plan sense before that can reap some really good benefits for our patients. Changes to swallowing is another time that we almost automatically trigger a medication review when a person's swallowing becomes impaired, or if we suspect it's going to come impaired, because often we'll need to start changing medication formulations. Some medications aren't suitable for crushing. But even considering sometimes you can get away with taking less medications and the patient will still be able to swallow them rather than ending up on their 12, 13 tablets in the morning. If a person's diagnosis might predict or precipitate there might be some swallowing difficulties, planning ahead for that is also really important. And we've got a bit of a slide on tapering medication doses. I'll talk a little bit about it then, but it's always a lot better to have planned medication withdrawal rather than being forced to do it because the patient now can't take medications orally. early conversations regarding some chronic diseases. So this is a little bit about maybe framing expectations and framing a future decline for patients. But a lot of the time, things like diabetes and hypertension become less important to treat aggressively as a terminal illness progresses or as a person gets older. Diabetes is a really good example that I see a lot in aged care. Towards the end of life, people stop eating or eat a lot less, have a lot more reduced appetite. And so some more aggressive diabetes regimens, things like basal bolus insulins and high dose sulfonylureas can become quite problematic. So talking to patients early on about this might happen later, could happen in a few weeks, could happen in a few months, few years, helps frame these scenarios, and it's less of a surprise when Mrs. Smith, who started on her insulin, now doesn't have to take insulin. And then if you're seeing patients with struggling with complex medication lists and regimens, so lots of different dose forms, lots of different dose times, more, like we said, towards the end of life, maybe more medications being added on. That's also another really good, I think, opportunity or time when deprescribing can be discussed. Normally, these are quite good situations because the patient will also be on side with you, and they'll be keen to start reducing their medication list if they're having problems. Few things we look at, so any obvious adverse effects. So if the person's having a regular symptom or side effect of a medication, things like anticholinergic sedative drugs can be quite obvious there. Complicated routines. And these even complicated routines can be things like medications that require to be taken with food, or to be taken on anti-stomach, or to be taken late in the evening or very early in the morning. Sometimes they can impact a person's quality of life. You always hear the old story of something like a frusemide that's taken every morning, and then the person doesn't want to go out for the next 6 hours to the shops or anything like that. So areas around deprescribing there can be quite useful. Difficult to use devices, particularly as we start to head towards the end of life. We can start to reevaluate things like long-term asthma treatments and eye drops and those types of things. You know, what is the long-term benefit? What is the risk that we're reducing versus the impact on quality of life that can happen there as well. Cool. Are there any questions or issues about any of those? Does anyone have anything to add? Have I missed a popular opportunity for deprescribing, or do you have any different opportunities in your practice? No? That was comprehensive. Glad to hear that. So deprescribing process, again, this is taken from a paper a friend Emily Reed has written, but I think she frames the entire process of deprescribing I think really clearly and really concisely, and it made it actually quite easy to structure for this presentation. So the process looks at a comprehensive medication history, and we'll go through all of these in a bit of detail, but this is a little bit beyond your typical indications, medications, and adherence check. Identify some potentially inappropriate medications, and we'll talk about a few techniques and ways to do that. Determine if medications can be ceased, and what the prioritization of ceasing those medications in a rational stepwise manner might be. And then we'll look at planning and initiating a withdrawal, a tapering, and what monitoring we might need to look at afterwards. So medication history. So I always really like to start my medication histories with patient experiences with medications and what difficulties they're having with their current medication list. I think a lot of the time when we talk to patients, particularly pharmacists in like a home medication review setting, patients have these preloaded questions ready to go. So getting a question open-ended like that out the way sort of disarms them and lets them get all those questions out early, and then they'll listen to you a bit later on. But I think it's really important to look at a previous history of deprescribing for patients. So PPIs is an example I use a lot in this sort of situation, but a lot of patients have had difficulties stopping PPIs due to their rebound of symptoms. So talking to patients about, have you tried stopping these medications before? What happened? and then thinking, is there maybe a better plan, a better way to do it? Or that could be something that you rules out that medication from deprescribing. If those symptoms return, a condition reemerges, then you can almost cross that off quite quickly and say, yeah, it happened last time, maybe something we need to be a bit more cautious about. Reviewing the patient's overall susceptibility to drug-induced harms. So looking at things like frailty, cognitive impairment, other geriatric syndromes such as falls. So have any of these been realized? Has the patient been falling? If you're talking hypothetical risk of an antihypertensive could cause falls, if the patient had a lot of falls, that could be related to an antihypertensive. I think that gives it a bit more of a reality and a higher likelihood of it's actually happening. As GPs, you guys actually probably might have a really good understanding of this already, which is really good. And you might, having that sort of ongoing long connection with patients, you might have actually been able to monitor and see this decline as well. So puts you guys in a driving seat for that. And then the patient's attitude to taking their medication. So similar to those questions we saw earlier on in the presentation about their attitudes to medicines, but I'm asking questions like, do you feel you are taking the right amount of medications? Do you feel you have too many medications? It can be a way to sort of broach a deprescribing conversation and seeing where the patient's thoughts along that path are. Then as part of their medication history, looking at medication administration issues. So things like swallowing, how they're going swallowing. Patients will often tell you if they've started to begin to have swallowing difficulties, oh, the big horse tablets are really hard to get down is normally what we hear first. Panadol Osteo is always no. And then talking to the patient about complicated medication regimens, particularly if we're looking at more than 3 dose times a day. There's a lot of evidence to point out that exponentially the risk of missed doses and medication misadventure increases past 3 doses a day. Ask patients about issues with adherence and remembering. They're always going to tell you they're fantastic and perfect about it. So sometimes you need to be more detective and sleuth, but looking at things like, are they using dose administration aids? Are they being reliably taken? Communicating with their local pharmacy to see, are they picking up their scripts regularly and on time? Is access to medications easy for them? So access can encompass a lot of different domains, but things like, can they afford the medication? Are they able to get to a pharmacy to get their medications? Are they able to get prescriptions easily? And prescriptions is something that can become quite tricky in palliative care. Lots of new medications added, lots of typically S8 medications are being added. This sort of complication between who is my prescriber, I have a specialist palliative care physician, I have my GP, where am I going? So that can be something that leads to access issues for medications too. So just having a conversation with patients about that. And, oftentimes I've organized things like deliveries from pharmacies or Webster packs, or it's as part of like a HMR I've written to a GP and said, we might need to organize regular appointments. These are when these scripts are running out. Let's make sure that they're written ahead of time. And then looking at along with that medication issues, things like how did the patient use devices? So tiny insulin pens, do they have the capacity to see the dial properly? Are they able to dial it up? And those type of things. And then I think, so this all takes a really long time, as I'm sure many of you know, but I think this is an area where pharmacists in particular can be really helpful. So considering things like a referral to a pharmacist for a HMR or an RMR if they're in an aged care home, or even as simple as a meds check. So I think most of you will be aware of HMR and RMRs, but meds checks are a free service that any patient can walk into a pharmacy without a referral and have a pharmacist go through their medication list. But collaborating with local pharmacists to have particularly this medication history component taken and can be something really valuable. And I'd encourage if you are looking to engage with a pharmacist, and particularly around something like this, emphasize on the referral that the medication administration issues are there, or you want a better oversight of the person's experiences with medications or their medication history. Because a lot of pharmacists will sort of jump in and be like, we're going to make some great clinical recommendations, but I think we sort of forget sometimes this fundamental component of, is the patient taking their medicine? Are they doing it effectively? Is one of the really valuable parts of our service. Now, this is just a little bit of my morbid curiosity. Do you regularly engage with a pharmacist or pharmacist for medication reviews? So I got a very often, sometimes not very often, and never. And I'd be interested to hear your thoughts on whether you think this process is valuable, is easy to do, because I have some issues with the process at the moment. So I'd be interested to hear from you guys. So I'll give you 30 seconds to jump on this one. And your answers won't pop up until later as well. Awesome. All righty. Good. So we got a bit of a mix between sometimes and not very often. And someone's I think we've got and someone with very often. So it's good. It's good to hear that very often and sometimes is winning. But for those that have gone not very often, I'd be interested to hear some of those barriers. It's probably a whole separate talk, but I know there is a lot of access issues to pharmacists and accredited pharmacists at the moment. But I think particularly around deprescribing and particularly around palliative care, there is a lot of value that we can add as pharmacists. So yeah, I really encourage you, reach out with your pharmacists in the area. If you're having issues doing that, contacting groups like the Pharmacy Society, or even I'm happy to sort of talk to you about emails, because there are lots of sort of opaque small groups of accredited pharmacists around that can be quite hard to access, but could be quite useful as well. So I'd be happy to facilitate anything there. Oh, have we frozen? No, we haven't. No, we're good. So the next step or phase in our deprescribing framework or adventure or structure here is identifying inappropriate medication. So we've spoken to the resident about their medication history, got a nice good history of that. And now we're going to look at that medication list and see what medications here could we rationalize for this individual. One thing I always like to start with is the indication still relevant? So oftentimes medications will be prescribed for something that might be curable or acute or just symptom-based and hasn't been an issue for a patient for a long time. So having a look at is that a medication that can be trialed to be stopped because that condition no longer is relevant? All medications that were started because of a prescribing cascade, and is that prescribing cascade still there? Has that other medication been stopped? Or can we look at that whole prescribing cascade and cut it off a bit earlier? Benefits of current therapy in views of goals of care. So this is particularly important around when goals of care have changed. But looking at preventative medications still providing benefit. If, for example, someone's had a reduced life expectancy, do the long-term benefits of some of these therapies, do the long-term benefits of something like aggressive diabetes management, are they justified? Are they going to be a benefit for a person with a reduced life expectancy? Looking at adverse drug reactions, this can be quite tricky, particularly if there's polypharmacy and it's a non-specific symptom like nausea, which everything might cause. But is there actually a realized adverse effect, or is this person at maybe high risk of a particular adverse drug reaction if they're taking something like multiple sedatives or a benzo and an opioid, thinking about respiratory depression there as well. So looking for some high risk scenarios where an ADR might become, which can become very probable, or the consequences of an adverse drug reaction can become quite consequential. So tools like the Beers criteria, I find really helpful for looking at things like inappropriate medications with adverse drug reactions. I really like the format that they've presented, as well as just like clear evidence base and clear advice on what to do. Looking at drug-to-drug interactions is also, I think, a really important part of identifying inappropriate medications. There's thousands of apps and websites to use there. I use either Lexicon or MIMS to plug in an entire person's medication list and have a look what comes up there. The reason I like those is they will categorize interactions into serious, not so serious, and explain why. One thing to be really cautious of is stopping an interacting drug. So obviously, if you think of there's a drug interaction, it's very relevant for the patient. We think we might stop that and change it to another medication. Stopping that interacting drug, whether it's an inhibitor or an inducer, could actually cause lots of side effects because now that drug it was affecting is now working differently. So being really careful around that whole process is something that we need to be on top of as well. Drug disease interactions. So the two really common palliative type drug disease interactions we might see are things like renal and hepatic impairment. So as renal and hepatic impairment will reduce, medications might not be cleared as quickly. The pharmacokinetics and dynamics might change a little bit. So medication that someone was stable on 5 or 6 years ago might now be problematic due to reduced renal function and clearance of that drug. So having a think around that. Length of time can be something that's quite tricky to combat with patients if someone's been on something for a long, long time and I've had it for 10 years, it's never caused me problems. And trying to explain to them now it might be almost sounds like you're trying to sell something sometimes, but yeah, it's a conversation that is quite important to have sometimes. And then looking at how drugs interact with other comorbidities, and sometimes you'll have medications that are going to interact with other comorbidities unavoidable. But if we can think of a different medication or a reduced dose might not interact as much with that comorbidity, might be important. So identifying inappropriate medication and adherence issues. Is the patient actually using the medication therapeutically? And quite often after we've gone through a medication history, you'll discover that there are some medications. So I had a case quite recently with an anticonvulsant where the patient was taking it probably every 3rd or 4th day. And anticonvulsants can be quite scary to deprescribe because of the consequences can be quite severe. But in this case, she wasn't really taking it. And the occasions where she did, are still exposing her to some risks. So yeah, having to think about, how the patient actually is using them. And sometimes you get some really easy wins there by saying, look, let's just take that off your medication list. It's obviously causing problems and let's stop it. And that is going into the same thing as subtherapeutic doses there as well. So some medications will have been attempted to be reduced and deprescribed in the past, and they've gotten down to a really, really small dose, which probably or might not be having any benefit. And sometimes they can be quite easy wins to stop because they're not providing any benefit. And there's still a risk of either causing more complexity and burden amongst their medication list, or sometimes a risk of adverse effects.
Julian,
Yes.
I'll ask you, well, I might make a comment, then ask you a question. There's a question
Great
in
question.
the comments. It's a very good one, which I will repeat. But the first thing is more of a comment on what you've gone through is absolutely all reasonable, but I can see why GP is one of the barriers is the complexity in time.
Look, I got a barriers list.
So
But yeah.
so these are all completely reasonable things.
Yeah.
Of course, GPs are time poor. They've got
Absolutely.
a lot of people to see. They'll be trying to do with these issues sometimes at 15, sometimes in a 30-minute appointment.
Yeah.
I mean, to me, it just emphasizes the need to get your pharmacist on side, and they can go through these things in a much more considered way using Beer's criteria and all that kind of stuff, which most GPs just don't know anything about. That's just a comment, really, but I guess all the people out there will agree. But then the question is, and this is probably going to pick up on a lot of those things that you've just talked about, and maybe also subsequently going to talk about, but how would you approach deprescribing for people who can no longer give a history? For instance, those in an aged care facility with severe Alzheimer's, do you suggest a trial of medications following discussion with the next of kin or guardian? Tricky. What are the medico-legal implications if the patient does develop an adverse event, i.e. stopping anticoagulant in someone with atrial fibrillation, severe dementia, no longer swallowing, bed or chair bound, then the patient develops a stroke and dies? That's a ripper of questions.
Yes. There's a few components to that. No, I think that's a really good. That's a really good question. So particularly in the aged care settings, that's where I spend a lot of my time. That can be quite tricky. So the patient's not necessarily going to give you reliable answers. But utilizing the staff there, so the nurses will be the ones that will be able to tell you, yeah, look, Barry doesn't take his medications in the morning. He'll spit them out at me. He'll run away. We have to fight him every morning. So that's part of that medication adherence. How does the person react to their medication? And all of these things need to be quite clearly documented. aged care homes documentation, it's tricky. And unless you work there, and I've worked at the one I'm at for about 2.5 years, and it's probably taken me a good 10 months to actually really work out how to do a deep and efficient dive through it. So yeah, as a GP visiting their site, once a week, once a month, it's going to be really difficult for you. It's an area where the pharmacists might be able to help you. It's an area where utilizing the nursing staff who know this resident really well is important. And then framing that individual goals of care is where I think the next of kin substitute decision maker. I mean, I think we're going to have one of the presentations later is going to be about substitute decision makers, but looking at what their advanced care directive says, what are their goals of care? Do they just want to have improved function, not preserve or prolong life? That might help you make some decisions about stopping things like preventative medications. Some of the medications that are kind of easy wins in patients with this category are quite obvious symptomatic medications. So things blood pressure medications that we can measure. The idea of making a really clear medication plan and deprescribing those medications and then making sure that staff are monitoring for obvious outcomes is another way to go about that. Case conferences are a really useful tool. So we do them quite a bit at Tanunda, but we'll invite a family member along, resident if they're able to. Even if it's a reduced capacity, having them there is almost makes you feel a bit more connected and responsible, and puts a face to the person you're talking about. And then having nursing staff, and we have carers. We'll invite lifestyle and physio. So that entire multi-D team to these conversations, because that's when we can discuss a lot of those advanced care and ongoing care plans as well. So yeah, utilizing case conferences, I think, is a really good model of care. And yeah, looking at in the future having pharmacists on site more regularly, it might be something that becomes a bit more viable going forward, another tool to be able to utilize. But yeah, no, that is a really good question. And then that anticoagulant component of it, you can flip that and say, I've left them on the anticoagulant, even though they have a huge has bled, potentially very small benefit from reduced risk of stroke. So yeah, so my understanding is that if you've done it in an approach to documented and evidence-based situation, particularly you've gotten consent from next of kin, and we've explained that risk benefit, sometimes the safer option would actually be to reduce an anticoagulant. So particularly someone who's having lots of falls, might be a really good situation that happen in. So it's important that when we're having these discussions, the risks aren't buried or diminished. You've got to be really clear and be like, the risk of us stopping this anticoagulant is mum could now have a stroke based on her AF or whatever the underlying condition was. But the risk of us not stopping it is when mum has a fall, she could have a bleed in her brain, which, and it's an impossible decision to make. You're not going to be able to look at a table and go, this is the right decision to make. But for that individual, I think if you document that clearly, I wouldn't imagine anyone's going to be mad with you. Does that reflect your opinions?
Documentation, absolutely.
Cool. That's a very good question. Thank you for that.
That's brilliant.
Cool. So we got through that. The other list of identifying inappropriate medications, I think, is medications that benefit or require tapering. So whenever I'm looking at a resident list, I'll look at some medications that I think are going to be tricky to stop later in life. And I kind of say to myself, if this person stops swallowing now, which of these medications are we going to have a problem replacing, or will require a taper? So thinking about the pharmacology and the pharmacokinetics of medications can be important here. Things with short versus long half-lives, you can get away without a taper, or long half-lives. Risk of recurrence of symptoms. So I use the PPI example again, but if we were to stop that person's PPI straight away, will they might get symptoms from that rebound. So looking at deprescribing that before that non-oral phase has begun might actually be of some benefit there. Adverse drug withdrawal effects. So if we were to stop a medication abruptly, having some serious withdrawal effects. So benzodiazepines for me is a really obvious example here. It induces risk of seizures and those kind of things. Can be replaced with subcut medications, but benzodiazepine conversions are a lot of art and less science. So if we can avoid doing those as critically towards end of life, and remembering, the community settings that I work in and a lot of you work in, these tend to happen Friday afternoon, Saturday night. So it's the young on-call doctor who's already had three on-calls at night. So if we can avoid them doing a benzo conversion at that time, I think it's a win for everybody. And then rebound phenomena. So things like beta blockers, which can upregulate receptors, slow titration down of those can be, or is normally really, really important as well. I've written a general rule of thumb about deprescribing or tapering, but typically reducing dose by about 50% every 2 to 4 weeks, with monitoring at each dose reduction, and the monitoring will be looking for adverse effects and that type of thing. Very big rule of thumb, some medications have specific monitoring, tapering suggestions, so look at those and find them, and I'm going to show you where to do that in a bit. But yeah, if you're stuck or if there's no evidence, because a lot of it will say clinician discretion, that's probably not an unreasonable rule of thumb. So I think Olivia might have flashed this up during the last presentation, but again, it's another really useful resource. Put a link to it down the bottom of the slide, so when you get the slide sent to you, you'll be able to see it there. But it's the medication cessation for adults in the last days of life list, and it kind of goes through some of the medications that we might have difficulty ceasing in the last days of life or ceasing without a taper, and some of the risks associated with those medications, so the symptoms associated with withdrawal. And then it's got some advice on how to manage those for a non-oral patient, so through subcut means. So really handy list to have. It's a handy list to have sort of if you've got a resource list, or if you're dealing with a lot of palliative care patients, having it stuck up in your office somewhere, and referring back to it and going, oh, yeah, there's some beta blockers on this list. Let's have a think about what our plan might be going forward with that. So this is sort of our last phase of the deprescribing process, but determining if medications can be stopped and what their prioritization should be. So we've now pulled together a list of inappropriate, or what we feel are inappropriate medications or high-risk medications. And the first thing we'd ask is, and this goes back to that collaboration with your patients, with their next of kin, if that's what's relevant, but is the patient willing to stop these? If the patient's flat out not wanting to stop the medication, you're not really going to have much luck. I think if you went into a situation where Mrs. Smith didn't want to stop her anticoagulant, but you did anyway, and then she had a stroke, maybe that's when you're going to start to get into legal medical issues. Is the patient medically stable and able to withstand changes to their medication, so they don't have like a current infection, or they're not in the middle of COVID, something that they might recover from, because that can make monitoring for adverse effects from the deprescribing also really, really tricky to undergo. Is it safe to do so now or in the future? We don't predict that stopping this medication now is going to have any adverse effects, but there might be an opportunity later in the future. Have previous attempts at deprescribing this agent been made? So we alluded to that a bit earlier about asking the patient, but if they have, talking to the patient about what attempt was made, and theorizing maybe why or why not, why it wasn't successful. Consider drug-drug interactions and how this might affect the current medication. So if we've got 2 medications we want to deprescribe and one medication is affecting another, I'd typically recommend stopping the one that's being affected first, then stopping the one that's affecting it, because you'll have less sort of unknowns and less, it'll be more predictable that way. And then looking at prioritization. So it's always good to deprescribe one medication at a time, if we can get away with that, which is again why that early planning can be really important. Because if we're looking at a patient's medication list and there's 4 or 5 medications we think could be deprescribed, this could take 3-4 months. Whereas someone approaching sort of that terminal end of life phase, we might not have the luxury of that much time. But yeah, prioritizing one medication at a time, because that lets us monitor for any same approach as starting one medication at a time, that you monitor for any adverse effects and making it easy to pinpoint what's been the cause of that adverse event. And then which medication first. Sometimes it might be good to start with easy wins. So sometimes I think they're really important for patients who are very hesitant to the deprescribing process. Get a few of the easy ones out of the way first, ones that you don't predict will have any withdrawal effects or any adverse effects. And that might get them a little bit more on board with it. Or if there's something that's quite critical and causing immediate harm, that's obviously quite an important place to start as well. So once we've got our list and our little plan together of what medications we want to deprescribe, I also think it's important we maybe quickly discuss the barriers and the enablers. So time was a barrier that was mentioned earlier. But yeah, I think that's a really, really important one. This normally takes a long process. But I've got a list of some of the barriers that I think the GPs face for deprescribing, but I'd actually be really interested to hear if you guys have any other barriers as well, just aside from time. But I think that is probably one of the most important ones. All right. Well, you guys have just predicted, obviously, that my list is going to be comprehensive. But so some of the barriers I think we face when we're deprescribing with patients. So if the patient still perceives there's a strong benefit to the medication, it's going to be really hard to take it away from them. Even if there is actually no benefit, sometimes people will still feel.
I've been told to take this.
My cardiologist, he's a good man, and he said I take this forever. Yeah, a lot of that. So there's a bit of that, and maybe that's almost like a smoking attempt. It's pre-contemplation, but each time we see them, we can talk about it in a non-confrontational way. When there's no actual harm has been realized, so I think it's really tricky communicating risk to patients. We saw it over COVID. All of us are pretty bad at actually understanding what risk is. So talking, you have a 2% chance versus an 8% chance of a stroke or a bleed. It gets a bit tricky. It's a little bit easy when, and not that we want patients to have harm, but when a patient's actually experienced harm. An example I can give is my mum was taking methotrexate for a while for RA, and she's just been told that she can come off of it. She was so happy. Obviously made her so sick, but it obviously helped her as well. But yeah, she was like, I'll drop it as quickly as I can. Whereas her other RA medications, yeah, you would get near stopping. Length of medication use, so kind of alluding to that point earlier, if someone's been on a medication for a long time, it almost becomes maybe sentimental and part of what they've done. If a specialist or other prescribers commence medications, talking to GPs, I've always found that's been a really tricky spot for you guys. And I guess my takeaway from that is clear communication with those specialists is an aspect of maybe overcoming that barrier. Limited time, so I did have that and I recognize that, but yes, as we can see, these conversations can take a long time, but this process can take a long time in a lot of planning as well. Lack of evidence, so there is evidence for some deprescribing and some expected outcomes, but again, we're looking at large population groups. The individual in front of us, it's quite hard to predict what's actually going to happen to them if we stop the anticoagulant, and that can make the deprescribing process quite tricky. And then some patients feel that sense of abandonment and giving up. So they feel like if we start stopping their statin, which the cardiologist said you need to take forever, it's sort of really helping recognize that the end is nigh. And that can be quite tricky to approach for patients. So yeah, that's some of the ones I thought of. If you think of any others, I see someone's put resistance from patients in the chat. I absolutely agree with that. That's definitely one of the huge barriers to it. But yeah, if you think of any others, chuck them in. We've also got some enablers, because I don't want to be all doom and gloom all night. But if the patient, and some of these are the opposite of the other ones, but if the patient has no perceived benefit from the medication, it can be a little bit easier to stop. So like I look at analgesia here sometimes when we started people on strong analgesia and they've had no change to their pain, quite easy to then stop that medication. You know, it hasn't worked. Let's remove it because there's no benefit. Experiencing adverse drug reactions to medication. So if they've had an allergic and a side effect of a medication, methotrexate example, that could become a lot easier to cease that medication. If cessation could lead to quality of life improvements, so things like maybe like insulins or bisphosphonates are one that a lot of patients would be like, I don't have to wake up at 6 in the morning once a week. Some yeah. So that can be something that framing it in that kind of way can be useful as well. Evidence-based guidelines, so they do exist and they can be helpful to talk to a patient about or talk through a patient with. I've always found it really useful to suggest trials. So particularly if we've got those combative patients that are quite resistant to the idea, suggesting a trial, I think helps them understand that, oh, I'm still in control, and if I want my medication back, I get it back straight away. So we'll have those conversations with residents at the home as well, and say we'll just try without it for a bit. And if the symptoms come back, you can have it straight away. We'll put it on your PRN list. The medication's not going to go anywhere, and I think that helps them become more at ease with it. And then I think medications that have easy to measure effects or outcomes, blood pressure, I used an example before, can be a bit easier to deprescribe because you're seeing a real-time, easy to monitor effects. Medications that are preventative and are reducing risk. Once you start that medication, you don't know if the risk is reduced or increased until if something happens later on. So a few things to think about. If you're seeing some of those, that might be easy to go through. And then the plan, withdrawal, follow-up and monitoring. We're nearly at the end, I promise, guys. But creating a medication plan from here, and that medication plan could talk about deprescribing or reducing medications over the course of 3, 4, 5 months. And that could involve prioritizing your medications. We're going to start with these medications. This is when our next appointment is going to be. And then documenting these changes to relevant parties, including a specialist who might be involved, palliative care specialist perhaps, or even talking to their community pharmacists, particularly if they're packing Webster packs for them. Nothing worse than packing a bunch of packs, patient coming back going, oh, I've had these meds changed, but they're not sure which one was changed. I think it was the green one, maybe it's half, I don't know. So having that clear plan there is good. And that can go both ways. If you've got nice, clear communication with your pharmacist, they can maybe do some of your monitoring for you as well. They can keep an eye on Mrs. Smith next time she's in, ask her about her pain, ask her about to do a blood pressure for her, those types of things as well. We love to get involved with those kind of things. Monitoring, so obviously we need to monitor the patient afterwards for any adverse drug reactions. That list provided by SA Health earlier is a really good baseline of what ADRs or what withdrawal effects we might expect. And then also looking for returning of conditions that maybe we've treated as well. Sometimes some medications might be really tricky to deprescribe, or we might need to do a few at a time. And sometimes things like a hospital admission could be an appropriate place to do that. So, talking to a consultant like Olivia might be a good way to organize and plan around that. Communicating to the patient is really important here as well. If you stop a PPI and all of a sudden their reflux comes back straight away, which we would predict, and if you haven't told them up front, they're going to think, oh, it's failed, I'm going to start taking it straight away again. So giving the patient some expectations and specific things to monitor and say, if this begins to happen, this is a really serious ADR, you need to go to the hospital, or you need to contact me, is important. And then and schedule follow-ups and schedule reviews. And again, you could utilize your pharmacist here. If we're deprescribing a blood pressure medication, a pharmacist is probably in a good position to be able to help monitor blood pressure and communicate with you about how the patient's going if you're short for time. Communication, ensure the patient has a method of contacting you or the surgery for questions and concerns. I think that's really important. It stops maybe unwarranted utilization of things like the ED department. I got some chest pain because my beta blocker was reduced, which is something that could maybe be handled differently. And then consider some non-pharmacological therapies to manage predicted issues. So examples are like if you're reducing analgesics, looking at massage or physio or other things like that. And use PPIs again. PPIs are a really good example here, but providing some PRN like Gaviscon or something like that might be, which isn't technically non-pharmacological, but might be a way of managing predicted withdrawals or effects. Cool. Now I'm just quickly going to touch on some deprescribing resources that I really like. These slides will get sent out then. So I've linked them all in here. So if you wanted to have a look at them, you could go through these slides and have a look at some of these resources. My absolute favorite are the deprescribing guidelines from the Tasmanian PHN. They're available through that link. They're free to use. There's about 12 of them, and they cover a whole host of different conditions that we might be prescribing. So things like antihypertensives, anti-diabetic drugs, benzodiazepines, antipsychotics, that kind of thing. I really like them because they're quite concise. They're fairly long because there's a lot of evidence in there, but they're evidence-based. They show you the evidence, but they have really good key summaries of what to do with particular patient groups or what your patients might look like and who will and won't, or who might and might not benefit from deprescribing. I think they're useful as two sources. They're good as a reference, so you could have them. I have them on my computer all the time, and you can have a quick look if you're thinking I'm going to deprescribe an antihypertensive. But they're also, I think, useful to have a read through and develop some background knowledge as well. The IAM medical guidelines app is really useful. It has a deprescribing.org sort of component to it, and it's available on Android and the other one, Apple iOS. That's the one. It's a lot more limited in terms of its scope, but I think its detail is really it's very detailed, and it will run through an entire patient scenario with you. So it'll ask you. It's kind of like an algorithm. It'll ask you a lot of questions about your patient, and then give you some evidence-based recommendations and some guidance on what to expect when deprescribing and the method of deprescribing, so how long to taper it, etc. So it's really useful. This one I have a bit of a love-hate relationship. So MedStopper, theory is brilliant, and when it works, it's actually really good, but it's almost like an interaction checker. You can plug in a medication list, and it'll give you some advice around deprescribing based on risk of harm versus risk of benefit. Doesn't always work. The website's just really bizarre. I haven't made it work on Google Chrome, but it works on other browsers. So if you're having trouble, try a different browser. But yeah, I really like it. I just maybe wouldn't rely on it at the moment because it's just, yeah, it's a bit buggy. And you probably can't read it, but it kind of gives you that summary at the bottom with quite a bit of detail about when you might want to and might not want to deprescribe a particular medication. And then I got the usual things like BS criteria, the start-stop list or the stop-start list, anticholinergic burden index, all really useful tools for sort of identifying maybe inappropriate medications, and ones that, familiarizing yourself with could be useful. All right, thank you all for sitting through that. Thank you for your questions and interaction as well.